It's nice to be invited to this. I was just telling Dr. Bull and Graham the picture that was on that was taken by, I think, Joan McParland when I was visiting the Stormont a few years ago. So it's always nice to be able to remember those fond times. So shout out to Joan as well. So I keep changing the name of this thing. I use the term PEM, or post-exertional malaise. And lately, and this is mostly in light of what's happened with long COVID, that term PEM, or post-exertional malaise, has started to merge into the term post-exertional symptom exacerbation, which may be a better description. I'm not sure. So if you see post-exertional symptom exacerbation and PEM used interchangeably, that's because PEM is typically used with ME, and post-exertional symptom exacerbation with long COVID. The idea of this presentation is quite simple. It's to try to avoid that symptom exacerbation by overdoing it. And one of the tools that we have to be able to do that is using a heart rate monitor to know when we're overdoing it and need to back off. So as all of you are very aware, post-exertional symptom exacerbation, whether we're looking at a word diagram like this, or I'll show you another picture in a second, it gives both healthcare providers and ME patients a vocabulary to describe how they're feeling. Sometimes it can be very challenging and difficult to recognize early onset symptoms, and how those can often lead into more long-term symptom exacerbation that can last days and even longer. Not only with ME patients, but with our newer patients with ME that we call long COVID, we want to help them be able to recognize that symptom exacerbation and prevent it. We know that preventing that symptom exacerbation not only improves quality of life, it actually helps manage symptoms, prevents the inflammation, prevents the long-term challenges that can often accompany ME. And so simply being able to pace daily activities using a heart rate monitor is a good tool to help prevent post-exertional malaise. This is a diagram that Stacy Stevens made, and we've done a number of questionnaires following a provocation with an exercise test to produce post-exertional malaise. And the time course you see over here on one side, these are the immediate symptoms that people often experience. And when you're doing heart rate monitoring, we want to help our patients be able to recognize the early onset. In other words, we want to help them to be able to identify the early symptoms when they're overdoing it. And obviously a heart rate monitor can help with that by giving that feedback. But then using that heart rate monitor with our perceived exertion and symptoms oftentimes can prevent these either short-term or long-term PEM symptoms. And if we can identify those early and understand from where they arise, typically overexertion, hopefully we can prevent the more long-term symptoms like a flare-up that produces more long-term flu-like symptoms. There's a number of things that can be helpful with that. Keeping a symptom diary is a great way to do that. Many of us have used energy conservation therapy to help with that as well. Today, we just want to focus primarily on heart rate monitoring. And I'm also going to present just a little bit of data about using heart rate variability, or HRV, as another tool that we may be able to employ with heart rate monitoring. But primarily, this is all about heart rate monitoring. And for those of you that haven't done this, there's several steps that you can follow to make this work well. And number one is to get a heart rate monitor. This sounds easy. I've tried a number of them. Many of our patients have tried a number of them. Usually you have to find something that you can work with. The picture that I show here is one we've probably used more than any other, and that's a Polar chest strap. The chest strap is not as comfortable as some of the wrist-mounted things, but it has a very high fidelity recording of heart rate. Garmin also makes one that goes as part of the chest mount. There are still inserts that you can put like on a sports bra, and even with the more modern Whoop, they can put some of those in clothing and garments. The idea there is to find something that you can wear and use that's relatively comfortable. Most people can tolerate a chest monitor during the day. They like to take it off at night. Some of the wrist-mounted devices like the Apple Watch and the Whoop or Fitbit can be very good options. You just have problems with the times when you're either bathing or have to recharge the battery. One of the things that is very helpful is something that has an alarm feature that you can set at a certain heart rate level. So it provides auditory feedback, so you'll know when you're overdoing it. That can be very helpful. Polar's good at that. And then some of the data that I'll show you today includes a record feature. And the record feature just lets you look back at a recording from the last, either day, weeks, and even months to see how your pacing activity is doing. So try to find a heart rate monitor that you can use. I think asking other people what they've used in the past, and then just taking the step, ordering something and trying it on is a good way to start. Heart rate monitoring is not new. It's something that's been done in athletes in a variety of other care situations like post-chemotherapy. What you're looking at here is just a 24-hour recording. You get your recordings of your heart rate at night while you should be sleeping restfully. You can look for perturbations in sleep. And then quite simply, periods of time when you have increased activity, you show a higher heart rate. This is a 24-hour heart rate. There's a blank spot here where there was either battery charging or somebody took it off in order to bathe. Some of the spikes that you see within those days on this subject may be periods of postural orthostasis where they had that tachycardia response. But you can see a nice recording. This allows you, and it reminds you that there were periods of time when you did an activity that caused heart rate to rise. And again, this is more typical of somebody that's more physically active. There's an activity here in the morning and an activity here in the evening, plus activities of daily living in between. And when you're looking at your heart rate monitor, these happen to be bouts of exercise in a physically active person. Heart rate goes up when exertion goes up. Heart rate returns toward resting levels during rest breaks. You can see on this is a series of 10 intervals, and you can see heart rate does not go back down to resting levels. And you can contrast that on the right. This is more lower intensity activity, where the bouts of activity are separated by periods of rest. Again, not to where you're completely recovering to resting levels, but there's a period of rest and recovery. This is showing during, quote, exercise. We want to apply the same kind of thing to just activities that we do in an interval type format so that we can, get more done without overtaxing our system. So there's 4 steps here that I'm going to go through quickly. So if you're new to heart rate monitoring, you just go 1, 2, 3, 4 when you're learning to use your heart rate monitor. And number 1 is determine your resting heart rate. This is your starting point that you're going to use to record how intense activities are. Also, you can use your resting heart rate if you monitor it day to day as a measure of whether you're getting adequate recovery from one day to the next. Number 2, some of you are familiar with this term, anaerobic threshold. Anaerobic threshold is an intensity where if you know the heart rate at that intensity, you can use that during activities. And the anaerobic threshold, as many of you are aware, is that exercise intensity where you start to rely more and more on anaerobic metabolism. And we want to use that as a gauge to try to keep our activities below that. We know when ME patients get above their activities at their anaerobic threshold is typically where you start to produce post-exertional symptom exacerbation. Number 3, learn to use your heart rate to pace all of your activities throughout the day. Using that heart rate helps you know when you need to stop, when you're overexerting. And if you have the opportunity, that you can sit down, lay down, put your feet up, remove extemporaneous input, and allow your body to recover. And what most patients find is that if they do things in bouts rather than one long activity, almost the way an athlete would do interval training, it allows them to recover to avoid the post-exertional symptom exacerbation. And then number 4, there's a lot of adjustment involved. If you're not used to doing this, it often, there's some frustration at the beginning of this that wanes, because you will find over time you're able to do more and to avoid literally days or sometimes days in a row where you've overdone it. And so I sort of say that enjoy heart rate monitoring. I put that word in there because it can be an enjoyable experience. It often is accompanied with frustration when you're first learning to do it. And what you'll find as you do it for weeks and even months, you won't need to rely as much on your heart rate monitor. You can rely more on your perceived exertion. I'll also show you a little bit on HRV, heart rate variability, like I mentioned before. Okay, so here's the first one. Find your resting heart rate. You want to do this when you're awake, relaxed, and reclined. So this is, of course, how I look in the morning when I wake up. Optimally, you want to get up, use the bathroom if you need to. You want to try to get a good resting heart rate. That resting heart rate is your starting point for activity, but it can also be a measure of whether you've overdone it the day before. The graph that I'm showing here is a 1 month recording of resting heart rate. And you can see there's a little bit of noise in resting heart rate. But one of the things that's very notable on here is you'll have these days where your resting heart rate is higher than you would expect. And usually we use about a 10% change is a sign that someone has overexerted themselves on that day prior. And for that patient that's doing this, they want to say, what did I do the day before to produce that? And now what can I do to help myself recover well so that I don't keep going with this symptom exacerbation? And you can see in this case, they overdid it one day. They used that day to recognize that, rest and recover. And then for a few days afterwards, their heart rate's returning towards normal. And you can see this cluster of days where heart rate's low. And actually you can see there's a trend here, a downward trend. This would be a sign of a patient that's using their heart rate well so that they can have better recovery. Typically, a response like this is someone that's more experienced doing heart rate monitoring rather than when you first start. Keeping track of your resting heart rate. This is the same graph that you just saw over a 1 month period of time. There was that day where they overdid it. There were these days where they seemed to be doing well. That downward trend in heart rate is very desirable. That's a sign of good recovery. Contrast that with this other month. You can see how heart rate's a little bit more noisy here. They had multiple days in a row where they overdid it, tried to recover, overdid it, tried to recover. And you see this up sloping resting heart rate. And again, that would be a sign of lack of recovery. And this is true in ME patients. It's also true in athletes. An elevation in resting heart rate is a sign that they need more rest, they need more recovery. And so keeping track of your resting heart rate can be helpful with things like that. Number two, this is the most challenging thing, is find your heart rate at your anaerobic threshold and use that to guide exertion throughout the day. The idea with this is quite simple. You determine an anaerobic threshold heart rate and then try to keep your heart rate below that. It's perfect if you've got the results from a cardiopulmonary exercise test or CPET. The results of the gas exchange tell you exactly where you're starting to transition from aerobic metabolism to anaerobic metabolism. That heart rate value is typically between 90 and sometimes as high as 140. There's a big variability in there because everyone is different, but that provides you with this output variable that you know when you're starting to overdo it. It's that sign that you're going from green light, continue with activity, to red light. It's time to start watching that. So if you have the results from cardiopulmonary exercise testing, you can use that to determine your anaerobic threshold. Many of us don't have that. So without a CPET results, a good starting point is to take your resting heart rate, add 15 beats per minute, and use that. I see Dr. Bull smiling just a bit because she knows this is a good place to start, but it can be very frustrating for the subject. Invariably, somebody will say my resting heart rate's 90. I add 15 beats to that. That's 105 beats per minute. That's not enough. It's a good place to start. If this value is too high, you're going to experience PEM. When you get close to that value, you're going to consistently experience post-exertional symptom exacerbation, and you need to back off just a little bit. If that value is too low, you notice that throughout your day, your activity becomes so intermittent that it's hard to get anything done. The nice thing is it avoids the post-exertional symptom exacerbation. So start with that resting plus 15, and then try to knowledgeably adjust whether you can do a higher heart rate value or whether you have to restrain that just a bit. This is your permission to stop activities. If you start, either your heart rate monitor goes off. I have a heart rate monitor that's set to vibrate, so it gives that feedback. You can often associate these that heart rate response with the activities that you're doing. You'll start to experience breathlessness, fatigue in your muscles, and then sometimes there's just that cognitive dysfunction that can only be resolved by stopping, getting in a recumbent position, especially getting your legs up, and then even you can continue with increased salt intake and compression stockings and things like that. But that heart rate is a good measure, at least to start with, where you need to stop doing those activities. Tying the activity to what produced the symptom exacerbation or the heart rate response in the short term is easy to accomplish, in that there's early symptoms that show you're overexerting. What can be challenging is when you did something either the day before or even a couple of days before that produces those symptoms. And in the longer term, sometimes you forget, I had to wait in line a bit too longer, or I stood doing dishes or activities, or literally talking to someone on the phone, or in a more animated way or an upright posture. So if you keep a symptom diary, and I put down here, journaling can sometimes help us remember what activity produced that response. And we remember in the future to try to use the heart rate or that exertion to try to tailor that so we become better attuned to our symptoms and then what that produces. And the heart rate monitoring is a good way to do that. There's a number of potential pitfalls. Hopefully you recognize these pitfalls so that you can avoid them, or at least recognize that they're there. Many people take beta blockers either to manage hypertension or to prevent POTS. You still can use a heart rate monitor, very successful, even if you are on beta blockers and experience POTS. The POTS show up as these big spikes. Those are often indicative of orthostatic problems, changes in posture and things like that, not necessarily from an activity as much as a perturbation in that. And so I underline on there, adjust the heart rate that you use in order to determine what's a real value versus what's a spike from POTS, or sometimes you'll even just get noise. On my heart rate monitor, every once in a while, I'll have a value of 205. That's not a real measure. It's probably either an arrhythmia or just some noise that was experienced in the recording. So those are potential things to be aware of, and try not to detract from being able to do heart rate monitoring. Just recognize some limitations. And then I don't want to take too much time to go over this. I just want to introduce this idea of using heart rate variability. I call this advanced heart rate monitoring, because heart rate variability is a very, very good way to determine recovery. And Dr. Bull and I were just talking for a moment before. My interest is in the autonomic control of heart rate and blood pressure. It can be very useful. If you have a good measure of HRV, heart rate variability, it can be help you understand on days when you're adequately recovered versus not. So with that in mind, HRV just shows you the rate of change in your heart rate. This is a ECG. They've accentuated it here. Each beat, there's a variability, beat to beat variability that could be recorded in a frequency histogram here, where you've got the rate of change in that RR interval. This used to be difficult to calculate back in the old days. We did this back in 1997 with heart rate recordings from animals. A lot of the, like Fitbit, for instance, the Whoop, the Apple Watch, all use a measure of HRV for recovery. So it is becoming more common to be able to do this. The nice thing is there's high frequency and low frequency variability. It tells you a lot about what's going on with your autonomic nervous system. High frequency variability is the more desirable. It's indicative of the parasympathetic, the rest, the adequately recovered. It's a sign of adequate recovery, as opposed to greater low frequency variability, which is indicative of the sympathoadrenal system. I'm just going to show you a quick recording here. These are HRV, heart rate variability. So what you're looking at on the y-axis here is in milliseconds for HRV. It's a noisy variable. It's more noisy than is resting heart rate. A sweet spot for HRV for most people is between 75 and 85, but it's highly individualized. And you can see when you've overdone it, HRV goes down, the opposite direction of resting heart rate. So these 2 days here where HRV was lower, that's a sign of inadequate recovery, needing more rest, trending towards post-exertional malaise. In this week, you can see there were a couple of days that were higher, good recovery, but then these days, lack of recovery. And you can see in all 3 of these weeks, it is a noisy variable, but can be very, very useful. Just like we saw before, again, this is HRV, not heart rate. That upward trend in HRV is a sign that you're using your heart rate monitoring, you're doing pacing well, and you're avoiding post-exertional malaise. That would be a sign that you're doing effective pacing. Again, that upward trend. I put here on the bottom, there's also some apps that you can use on your phone where you literally put your finger over the top of the camera. It's a noisy variable, like I keep saying, so you want to do this over a long period of time to start getting an idea of what your own personal HRV is. It can be very, very helpful. Just in summary, successful heart rate monitoring, find a monitoring device that you can use that's comfortable enough. Find your resting heart rate, use that resting plus 15 for your anaerobic threshold. And please recognize it requires time, diligence, dedication, and a long period of adjusting. And then I added that word before, it can be an enjoyable thing to undertake because you'll find you'll be able to do more, and it gives you that peace of mind to take rest breaks so that you can do more or accomplish more throughout the day while preventing post-exertional symptom exacerbation. Since we're recording this, there are some resources on our webpage that can be helpful at the Workwell Foundation. So hopefully, Michelle, I didn't go too long. We can take some questions at the end, but thank you very much.
Okay, so thank you very much for inviting me to speak today. I'm speaking on behalf of my colleagues from Physios for ME, who we are a special interest group of physios, and one of our aims is actually around education for physios and other healthcare professionals, so it's a real privilege to be here today. And our Twitter handles and our website details are there, and I'll put them up again at the end. So I'm going to cover over a few things. There will be some similarity and crossover between Professor Van Ness' talk, but hopefully it will build on that. And then you can ask us the questions at the end. As I've already said, Mark's having the tricky questions. I just wanted to literally flag a few things as we go through. And I know this is, some people probably be aware of all of this, but ME is that complex multi-system disorder with PEM or post-exertional symptom malaise as the hallmark symptom. And that post-exertional malaise, and I think this picks up the point that Mark made around it's not just about fatigue, it's everything from poor concentration, sleep disturbance, joint pain, sore throat. It's often can come on 24 or up to 72 hours after exertion, and that's physical, mental and emotional exertion, and it can persist, as Mark's talked about already, for days, weeks, months or even years. There are other symptoms as well that are quite common for ME, and it really is that multi-system condition. So it's, and I think my biggest learning from it has been that no one person is the same. So it's really important to say our treatment and our approach has to be individualized as well. There's a scale here that looks a bit about, and I'm whizzing through some of these, but obviously you'll be able to go back and see these on the recording, that gives us a bit of an indication around where somebody is, which can help, but from a physio perspective or from any sort of intervention around where we're starting from. Somebody who's really bedridden and sort of 10 on the scale really have to think about what our intervention is and where we're best placed, whereas you can perhaps be a bit more adventurous slightly further up the scale. I think it's one of my learning has been very much about the importance of screening for post-exertional malaise, and I would say that's been even more so with long COVID, and about trying to get people to understand the links between their activity, and that's physical, and reiterating that mental and emotional social activity. The questionnaire I've put here is the DIPAL symptom questionnaire. It's a good screening questionnaire. I think we use it to sort of try and identify people that could benefit from the work, taking these sort of approaches, but actually the best thing is around doing a really good subjective assessment and asking the person. And I've put extreme care with any physical tests, because quite often I know as a healthcare professional, you're supposed to do a pre and a post so that you can demonstrate the improvement. And certainly I know for some of the long COVID protocols that you're supposed to do a 6-minute walk test or a sit to stand, and that's enough to put people back into a state of post-exertional malaise. So really about extreme care when using that. Touched on this before about how physio needs to be individualised. It also needs to be monitored and constantly evaluated, and that point I made that every person with ME is different. So therefore, what I'm talking about with some of these treatments and sort of interventions, it's more like a toolbox, and you have to pick the ones that are right for the person that you're working with. I'm going to talk a little bit in more detail about pacing. Mark's talked about using heart rate monitoring to support it. I'm going to talk a little bit about the mechanics and really this energy management approach. And just to go back to the sort of beginning of where pacing came from, and around the idea of an energy envelope, that you've got a defined amount of energy that you can have to do all your activities in a day without triggering an increase in your symptoms. And that energy management approach, or energy conservation, is around taking a strategy that involves managing your activities to stay within that envelope. So the energy envelope theory, no surprise, is around how do you manage ME by maintaining those energy levels. And it actually, as we've mentioned before, means that you can sustain physical and mental activities by reducing the symptom severity and reducing the frequency of PEM. And individuals need to work on their perceived individual energy levels for a daily basis, and then use it to gauge their energy for a day. I'm just going to show you a graph. It's quite old, but I think it's brilliant, and it measures fatigue on a 100-point scale, and it measures perceived exertion, perceived energy and expended energy. And you can see on the top left that this is one individual person. That sort of boxes on the bottom are the perceived energy that they had, and then the spikes are the expended energy that they used, and then the bold line along the top is that fatigue that basically was fairly high up on that scale of fatigue. On the bottom right, when they started using the energy envelope approach, again, the blocks were the perceived energy that they had, and their expended energy was much closer. And you can see, therefore, that there was a significant drop in their reported fatigue as well. And I just think there's a really good diagrammatic representation of the difference that you can make. And actually, when they started to spend more energy than they had, you can see that their fatigue increased. So it's only one person, but it's a really good example of how it actually works in practice. You also need to remember, though, that if your energy levels are higher than usual, you don't really go for it on that day to make up for all the days when you felt a bit rubbish, because then you're sort of lurching from this sort of crash to lots of energy and then crash. So it's more about trying to stabilise and find your baseline. And again, recognising that that PEM may be delayed. So you might not feel it on the day you do your activities, but you need to remember. And one of the things I found really useful is people to understand when their PEM comes on, and not to try any activities. So if their PEM starts 48 hours after, they don't try and add anything in until 48 hours after their activity. So using that energy envelope has really brought pacing into the sort of main field. But I think for me as a physio, again, I've had a lot of learning and a lot of having to reevaluate my practice, because traditionally we use a quota contingent type of pacing, where we basically, and particularly for things like cardiac rehab and cancer rehab, we might aim to say to somebody, walk for 5 minutes every day, and then add on next week it's 6 minutes every day and 7 minutes every day. And it's ultimately working towards 30 minutes a day, 5 days a week, which we know is the sort of guidelines for physical activity. However, we're dealing with a group of people here who are really have to work differently with their energy levels. And so we're looking at that symptom contingent pacing, i.e. avoiding symptoms and conserving energy. So energy management, to reiterate that, is it's not quota contingent pacing that we've used, and also people use it a lot in pain management and fatigue, and for people who appear to be deconditioned and need to gradually increase in their activities. But this is not the right approach to pacing for people with ME. And putting it out there, graded exercise therapy, graded activity therapy, however gently it starts or progresses, it hinges on that concept that the person who's being treated is deconditioned, whereas people with ME have an abnormal physiological response to exercise. We've pulled together this table of those physiological responses on our website, and probably a lot of these are work that's come from Workwell. And you can see the first column is the normal response to the different to exercise and activity, and then on the right hand side it's what happens when a person with ME exercises. So you can see that there's quite a difference between normal and ME. So we can't take those same approaches. I really like the idea of the energy budget bank, and actually as a way of explaining it to people, it's quite easy to understand around the different ways in which you can use your energy, and how if you've got limited energy, you need to use that for the things that you must do. So those basic activities of daily living that as healthcare professionals, we know people really want to be able to do. And then you can look at saying, and any other activity, then you can build on that and move forward. So trying to work towards having those 4 energy accounts. And this is taken from the International Consensus Primer, so you can read that in there. So energy management in practice. It sounds easy and straightforward, but actually it's really tough. And if you've ever tried it yourself, you'll realise how hard it is. So the first thing is to establish a baseline and record your activity and your symptoms over 2 weeks. And that's that physical, cognitive and emotional activity, and try and understand what recognises causes pain. I quite often say to people, if they're having a really bad time and it's been a prolonged bad time, is actually strip out everything that's non-essential and see what happens to that. And some of my patients have called it rest weeks, and they've really noticed a difference. And then it allows you just to be able to stabilise those symptoms before looking to increase any activity. Restorative rest, actually taking regular rest breaks during the day where you're switching off, and that's properly switching off. That's not watching TV or reading a book, it's just resting for rest's sake. Mark talked about switching activities. So if you're doing something like reading a book, then you switch to doing something like cleaning. And then, although you would choose and put cleaning that's an essential activity, and then go back. So rather than doing 2 hours reading a book, you break it into 15-minute chunks, intersperse it with 15 minutes of something physical. And so looking at breaking down those activities, I talked about cleaning. You might get the cleaning activities out, wipe the sink, and then have a rest and go and chop some vegetables. And then you might go and sit and read a book for 15 minutes and then breaking things up in that way. There's a lot we can also do around energy conservation, about thinking about body positions. So using aids like an electric toothbrush, for example, or using a wheelchair. Shower seats is a big one, and that people find really helpful. And also changing the position you do things, like I've just mentioned, chopping vegetables, sitting down when you're chopping the vegetables rather than standing up. And timers are really good to help prevent overexertion. So that might be, you can use some of your devices to tell you how long you've been doing something. Then prioritising and planning are the other P's that are really important, and what needs to be done rather than what could be done. And I've certainly found that when I've asked people to write a list of their essential activities, they've realised just how much they do in a day. And then planning ahead. So if you've got things that you absolutely have to do, say you've got an appointment with a doctor or physio, on that day, you don't also plan to go out for coffee with your friends and also plan to try and do some walking. Mark mentioned journaling, and very much I would say use a diary, especially at the beginning, to help yourself get into understand what your weekly rhythm looks like. And also we've mentioned on the post-exertional malaise around cognitive impairment and around brain fog. For some people, it's hard enough to remember what they had for breakfast that day, let alone what happened 2 or 3 days before, to be able to see what might have brought on their post-exertional malaise. So by just keeping a diary, I would also add it's really important that keeping the diary shouldn't become a demand on people's energy levels. I've had somebody who presented me with this massive spreadsheet of almost every 10 minutes when they switched their activity. And they said that they were actually getting fatigued just filling in their diary. So there's something about finding a balance. And I tend to start by just saying, write the things of a note down, and then we can drill down further as we need to. You can try using the Bearable app. Some people find that an easy way to do. I found it quite hard to actually set it up. So it might be something that you suggest that they get a friend or a colleague, or you yourself help them set an app up. That's a sort of bit of cover over pacing, and just wanted to pick up some potential physio support for severe and very severe, which I kind of touched on at the beginning. And it really is a less is more. And again, it's very individualized. I put maybe gentle massage or myofascial release. Some people can't even tolerate that. Some people can't even tolerate the noise of you being in the room. Positioning, I think, is an underrated physio skill, and we've seen really just by supporting people with pillows how it can make a difference to their quality of sleep, and therefore once they get better quality sleep, they feel they've got more energy to carry on. So some really simple things that we can do as physios. I've put oxygen therapy and Perrin technique, debatable, but some people say they've helped. So I'm literally just putting it there. But again, we're not graded exercise therapy. And for this, there's something, as I think, as our role as healthcare professionals around supporting family and carers as well, to how they can support and help people. Mild to moderate, if you go back to the scale I showed at the beginning, they're having to plan every day. They can do some short distances. They might have brain fog, and they can't exercise and they can't walk. So the types of support that we can do for that group are pacing, prioritising, planning, as I've talked about, mindfulness, heart rate monitoring, which Mark's talked about. I'm going to mention a little bit, but again, not graded exercise therapy. So it's that balance, pacing, prioritising, balancing activity and rest to bring about improvements. And by that activity, it's that mental and emotional as well as physical activity, and relaxation being really important, as well as prioritising. Heart rate monitoring, and as I said, hopefully we're fairly aligned on the messaging that we're putting out here. A little bit of physiology, first of all, quoting from my colleagues at Workwell, in that we see that abnormal physiological response, and that the heart rate rise in cardiopulmonary exercise tests for people with ME and is blunted, which means that they don't have the same response and that they can't increase their cardiac output in the same way. So therefore, we have to think really quite carefully about how we use heart rate monitoring. And as Mark's already said, the most accurate way is of determining your anaerobic threshold is by doing a cardiopulmonary exercise test, which in itself is a massive ask for somebody with ME, and also isn't necessarily always available. So you can use, and traditionally people have used that anaerobic threshold at 50% of their maximum heart rate, which is very much aligned with the approach that we use in cardiac rehab. However, as Mark kind of shared earlier, it's that 15 minutes above resting heart rate, which everybody, when I tell them that, they give me the sort of look of like, but that's not very much at all. And I think that's where I have used both of these ways of calculating upper limits, and it kind of depends on things. Again, it's that individualization. If somebody's got more severe PEM, takes longer to recover, I would underestimate, and if somebody's got perhaps recovers more quickly and their PEM's not so severe, I might be prepared to take it using something like their anaerobic threshold. I mentioned the podcasts, as I said, with Mark's colleagues from Workwell, so you can find those on our Physios for ME website. Those, I appreciate that it's probably quite hard to write those links down. I just wanted to, I've got a couple of slides from those podcasts that I won't go into a lot of detail about, but some people use different ways of calculating their heart rate and different ways of using their zones, and look at sort of the zones: easy, moderate, hard, very hard, and maximal on the right hand side in the colours. And then you can see that the example in the top, which is a bad day, is most of their time was spent in the yellow, amber and red zones rather than in the green and blue. And then on the well-paced day on the right, much more around the lower levels. And also, just to pick up, Mark talked about alarms and vibrations, and I think they can be a really useful tool. I think one of the things that we've found is that people can sometimes get a little bit over-reliant on their heart rate monitors to support them, and so there's something about sort of trying to get people to really dial into that perceived exertion rating that we talked about, so that they can use their heart rate, check how they're feeling, and then gradually they can do it more as a sort of instinct on how they're feeling rather than having to have alarms going off all the time. Some of the difficulties Mark mentioned again before around orthostatic intolerances, but even just if you're holding your arms up, or if you're doing different postures or standing still, or if it's hot, or if you're dehydrated, they can all affect it. So it's really, I really like the idea of enjoying it and using it to learn about how your body responds. I think we've hopefully sort of sold the benefits of heart rate monitoring and how it can support avoid going into PEM. I think it's also useful to raise that awareness of how hard your heart is working, and also can give you some hard evidence that you can share with other people and provide a stimulus around needing to rest with those patterns. Again, linking in with what Mark said, a bit of information around heart rate variability. It's that time in the interval between consecutive heartbeats, and it always slightly confuses me because you actually want more variability, whereas most things you try and like get into a standard routine. But for a normal response to stress, you have that constant variability, and it's a non-invasive marker of autonomic nervous system activity. So the more increased your heart rate variability, the better your ANS is working. And I've just put this sort of snapshot of some of the data that we've captured as part of the research that we've been doing. We've been doing a feasibility study to see how well people with ME cope with wearing equipment. And this is some of the heart rate variability data that we've had. And one of the things that we know is that people with ME can have a sort of metronomic heart rate with little variation, or else they can swing around all over the place. Now, this data, I know that, so the light blue blips are around where there was light physical activity going on. And the maroon blocks are what is described as stress reactions. So I know that those stress reactions were when this person was sitting doing not very much at all. So you can really see that things are slightly abnormal in this cohort. And I'm just looking at my phone because I've had a message from one of the other physios who's basically said, over half the participants in our initial feasibility study that we're doing have had 0% recovery at night time, so are absolutely not getting decent quality sleep. So just moving on to the next slide, a bit around how to use it. I think Mark's covered that, so I'm not going to spend too long, but it just, and you can always read back on it, and we've put a web link to some of the other websites where you can find some information. And basically a warning, a rise of resting heart rate in the morning can give a clue that perhaps your day shouldn't be a highly active day. And then your heart rate variability, a lower heart rate variability indicates a potentially bad day. Just briefly to touch on autonomic dysfunction and some autonomic or orthostatic intolerances. So normally when you sit or stand, gravity pulls your blood down and into your belly, your hands and your feet. And so your blood vessels quickly contract and your heart rate increases to keep that blood flow to your heart and to your brain, and to prevent your blood pressure from dropping. all of which is done without thinking about it, is what your ANS does. But in postural orthostatic tachycardia syndrome, or POTS, it doesn't work properly, and that doesn't happen the way it should, and so you see the significant increase in heart rate. And you can screen for these using the active stand test or the Nassaline test. Tilt table test would be the gold standard, but we don't all have access to gold standard tilt tables, excuse me. So you can do some of these just in a normal treatment clinic room. So active stand, you measure your heart and blood pressure after resting and lying, then immediately after standing, and then after 2, 5 and 10 minutes. I hear about quite a lot of people who say they made me lie down, they made me rest, and then they took it after 1 minute and said it was fine, and so I could go. Whereas actually we know you need to do that for longer. And I love the quote that I found when I was trying to make sure I got the full detailed protocol of the Nassaline test. So again, you lie down, you stand slightly, feet slightly away from the floor, shoulder blades against the wall, and you stay there for 10 minutes, and you look at measuring your heart rate and your blood pressure. Just as the same as the tilt table does, it takes any skeletal muscle pump action away from your body. So it is you, your baroreceptors, your heart, and your ANS on your own. How do we use the findings from that? So your diagnosis of POTS is made if your heart rate increases more than 30 beats per minute, or 40 in the younger population, or if it increases to more than 120, and that's in that 10 minutes. So on the active stand test. So just doing it for a minute isn't going to show you enough. Or you could demonstrate orthostatic hypertension if you see that postural drop in standing. Just thought I'd drop in a couple of indications around physical activity if if you've got autonomic dysfunction or orthostatic intolerances. Interventions could include autonomic conditioning therapy, which has been sort of coming out more from, we've seen quite a lot of that around long COVID, but also thinking about the position that you do exercises in, the type of exercise, compression garments, and also education around hydration and salt sticks. Some protocols suggest aerobic exercise for POT, and there is good evidence, but again, you must take post-exertional malaise into account if that's also present. And if you are using heart rate monitoring and you have got autonomic dysfunction going on, maximum of 2 minutes to allow that heart rate to settle when pacing. Otherwise, you could start to induce your post-exertional malaise. So really, just to summarise, that if we are looking at any physio intervention, it must be individualised. It could be from putting pillows under somebody in a bed to doing some quite more advanced exercise planning. It needs to be monitored. It needs to be monitored for a period of time, not just like how are you feeling immediately after you've done your exercise in the treatment room, but also how when you get home, and for the next 48 to 72 hours, and then constantly evaluate and work with the person to see what's happening and how we can take it forward. So there's our link to our website, and again to our Physios for ME Twitter handle, and we've got a Facebook page as well that you should be able to find us on. And I'm going to stop sharing my screen and come back to the main room. I mean, and that's quite a common question that we get asked, and it is and it is really, really tricky, because obviously if somebody's bedbound, they're bedbound because their symptoms are so severe, and then you're looking at even just sort of doing passive movements, but that might be enough to cause an increase in somebody's symptoms. So it is really a sort of a fine balance, and how you work with it. And you know, ultimately, I really wish we could find the cure so that we can not be dealing with that type of question, because it really is what can you manage, and working with the person to sort of say, what can we look at? I think I use the example about the pillow for positioning as because for me it was such an eye-opener around that made such a difference to somebody. So yeah, it's really tough, basically, and I don't know whether there's anything more I can say on that, but it's around finding what you can do that isn't going to exacerbate somebody's symptoms. So I think it's one of those challenges. So I haven't worked a lot with people with fibromyalgia, but my understanding is that if you only have fibromyalgia, you tend to do better at exercise. But obviously, fibromyalgia and ME go traditionally hand in hand. So in the same way as I said, if somebody's got POTS, you need to use post-exertional malaise as sort of the guiding feature. It's absolutely the same with fibromyalgia. So if they've got fibromyalgia and ME, I would say use the post-exertional malaise and the ME as the sort of the barometer for your exercises. But there's no reason why pacing, heart rate monitoring, and those types of things shouldn't be a tool that you use for somebody with fibromyalgia. My answer to that would probably be actually it's the opposite, and that normally it is about trying to support people to do less rather than to engage to do more. And Mark's nodding, so I think that, again, it's around that's looking at all our skills, isn't it, as a health professional, and how you do your motivational interviewing, how you find out what's important to somebody, how you can find out the one thing that they might be interested in, and then say to them, how can we use that, break down use some of the tools that we've talked around pacing. The person who springs to mind most recently that I've worked with is a lady who basically lost all her appetite with long COVID, but she loved making soup. But she was like, I can't sit and chop vegetables. I can't do all of this. And we actually but I feel I haven't got any energy. So we literally stripped apart the process of making soup into chopping vegetables. Could she buy chopped vegetables? Could she put them in a soup maker? Could she use a slow cooker? And actually she reported back that she'd started to then get a little bit more interest, and then gradually built up from there around going and choosing vegetables. And so it's a really, again, it's like an individualized approach to finding out what somebody is interested in. But it's more, for me, it's more around people are probably more keen to do more. I had another lady who just basically said, I absolutely did all the exercises perfectly, it was great, but I felt so good I went out and chopped the bushes down in the garden. And I'm like, no. But that's the sort of balance again. I don't know, Mark, if you'd want to add anything on that around motivation to engage.
I thought your point about allowing people to do less is very, very important. I've seen oftentimes family, friends and loved ones talking about how they helped their family member with ME get up and move around and do more. And they need to use that heart rate monitoring to do less to allow themselves to recover. I think that's a very, very good point. I think for any of us, seeing success stories provides motivation. And so when they see an ME patient that has used pacing and has gone, wow, I don't spend so much time with flu-like symptoms because I've learned to pace better, that's great motivation. So yeah, and I think that's true with weight loss and exercise and not chewing your nails or something like that. It does, when you see success stories, those provide or help with motivation. And I know I hear a lot of these from Stacey Stevens and Todd Davenport because they work more with the patients. Michelle, I think that's the same for you. Sharing those success stories is wonderful.
Thank you.